Hello, good day to everyone. We are so delighted that you made time on your schedule to join us in our very first Genomics of Kidney Disease webinar. My name is Mira Keddis. I'm one of the nephrologists at Mayo Clinic in Arizona. I serve as the Associate Director for Education for the Center for Individualized Medicine, who is graciously sponsoring our webinar series. And a special thank you to Christopher Scott and Kara Mangold, who are our CIM education support team, who helped make this webinar possible. The primary goal of this series is to bridge the gap in knowledge between the busy practicing nephrologist and what we know about genomics of kidney disease today. I take a lot of pride that as a nephrologist, we have seen a lot of progress in learning about genetics of kidney disease and how that has and will continue to transform the practice. So it is my goal to bring this knowledge in a practical way to the practicing nephrologist in the community. So without further ado, I'd like to give you a little bit of a perspective of how this webinar series will work. So this is a conversational approach where I will ask our speaker panel questions, and we will have ample time between 15 to 20 minutes at the end to allow for a robust question and answer session, which will enrich the discussion and will also give us future topic ideas for future webinars. And as you will find out, our invited guests are expert contents and phenomenal educators. And today we're really fortunate to start off our series with Dr. Filippo Pinto, who's a medical geneticist at Mayo Clinic in Arizona, Mayo Clinic in Rochester. Welcome, Felipo. We're glad you're here with us. We'll start our webinar by just getting to know you a little bit more, who you are, how you got interested in what you do, and what your current role is at Mayo.
Awesome. Thank you very much for inviting me. It's a pleasure to be here and talking with our colleagues in nephrology. And I would like to thank the SIM team as well, because they've done wonderful work on putting together this series. So as a start, as you said, I'm a medical geneticist. I did a PhD in genetics and molecular biology. And then I started my career caring for patients with lysosomal diseases. And we had a very, very busy Fabry disease clinic when I started to interact more and learning more from our colleagues in nephrology. So nowadays, I'm the medical director for the SIMS program for rare and undiagnosed diseases, what we call PROUD, so the acronym. And with this program, we have been establishing some partnerships with multiple departments and divisions across the institution to help patients with undiagnosed diseases by using genomic testing. And our main goal is to integrate into the practice the whole process of ordering the test, interpreting the results, and counseling the patients properly. So we started in nephrology with Dr. Fervenza, focused on FSGS about 3 years ago, and we were very, very successful. And then we started a pilot with Dr. Hogan for other phenotypes, such as cystic kidney disease, tubulointerstitial disease, stones, and so on. And again, we have been very successful. So that's why I'm here today. My goal actually is to set the stage to other colleagues, such as Dr. Hogan, Dr. Eltiers, Dr. Zayden, and Brittany Thomas, who's going to talk about the whole process of the genetic testing, ordering, and interpretation.
Thank you, Filippo. So you're setting the stage for a whole host of awesome speakers who will give us a spectrum, like you said, from a transplant nephrology standpoint, kidney stones, genetic counselor, FSGS with Dr. Zand. So we're really excited to learn from all of you. So let's take a step back and reflect a little bit about indications for genetic referrals from nephrology. What has been the pattern in the past, and how have you seen it change, say, in the last 5 years?
That's very important. So historically, in genetics, we've seen patients coming from nephrologists. These patients had strong positive family history, right? Anytime that someone in nephrology, they saw a patient with, let's say, FSGS, and they have 3 or 4 affected individuals, they would refer this patient to the to the geneticists to do genetic testing. Other group of patients would be children, usually children with congenital malformations. So this was a big group of cases that we usually see in the genetics department as well. And other patients with extra-renal manifestations, right? Like eye disease or ear problems, hearing loss, and so on. And other individuals with very specific phenotypes, and we've seen a lot of those as well. So for example, patients with adult onset polycystic kidney disease, even though we know that PKD1 would be the main gene, many times the nephrologists couldn't or didn't have the time to order the test, or for any reason they couldn't order the genetic test, so they would refer these cases to the geneticist as well. But what's very important is that usually it's very rare to see an adult with late onset of hematuria, for example, in our genetic clinic. So usually these patients stay in the nephrology division. And we know now that most of, or many of these cases, they do have a genetic disease as well.
So you talked a little bit about polycystic kidney disease, perhaps adult patients with hematuria. Now that we're getting more traction, right, about learning how genetics may be powerful in identifying what they have and how that may impact their prognosis or treatment plan. While historically, it's been really positive family history, whether known or unknown, right? And then with children. So maybe we're expanding our understanding of different causes of kidney disease by taking advantage of genetic evaluation. Along those lines, would you be able to give us maybe a perspective of what used to be available to test for, say 10 years ago versus now, just from a broad standpoint, as far as genetic testing that's available to evaluate patients?
My pleasure. So I do have some slides, and before we talk about a little about the genetic testing, I think we could review like some concepts, and I will share my screen just in a moment here. Give me one sec. Can you see my screen? Great. So just to remind you that what's a gene actually, right? So before we talked about the genomic testing and genetic testing. So this is a gene. So the genes are in chromosomes, as you can see here, but the gene is, there is a part of the gene that we call upstream. So there are some promoters and some enhancers and other things that usually, and that's why I'm showing this here, usually these parts are not covered by the genetic testing that we order from the clinical labs, right? And then there is a downstream part as well. So this is the core of the gene, right? So you have these green parts that are the exons, and then you have the orange or pinkish parts here that are the introns, right? So anytime that you see or read in a report saying that someone sequenced the whole gene, this is not completely true, right? Usually the parts that are sequenced are the exons, the green parts, sometimes a little bit of the exon-intron boundary as well, and these parts are important because there are some very specific variants there that are usually very deleterious. But most of the times we don't have any coverage for these regions, this part here and this part here, okay? So this is important to understand why sometimes we have some negative results, and we talked about, okay, so what parts of the gene weren't covered, and we now need to do some sort of testing to cover for that part, those parts as well, okay? So to compare, so the three main types of genomic testing that we apply in nephrology, they are called multi-gene panels, exome sequencing, and out of the exome sequencing, you can actually develop some what we call exome-based panels. There are some labs that they call this a slice of the exome. There are some labs that call this a customized panel. And the first one, the first panel here, we call them targeted panels, and they are curated target panels. And we have the genome sequencing as well. And to compare these three, I put some bars here. I hope you can see this. So for example, First is the number of genes that we can test using the different types of testing here, right? So when we are talking about a panel, usually you are very focused, right? You can pick like from 1 to, I would say, like 100 genes. Of course, you can do more, but usually that's what the clinical labs, they do, like up to 50 to 100 genes. And then with exome sequencing, we are actually sequencing 20,000 genes, about 20,000 genes. And then you can pick the genes that you feel are more important for the phenotype that you are interested in. And then that's what we call the exome-based panel. So you sequence 20,000, but you don't analyze 20,000. You analyze only, and I would say like 400 genes or so, depending on the phenotype. And then we have the genome sequence. Oh, just one thing. Exome sequencing, meaning that you sequence only the exons and very little of the introns. Okay, and then if you do genome sequencing, then you're sequencing all the exons, all the introns, all those parts that I was telling you about that usually are not covered with the other types of testing. And then we have to talk about coverage, and I'm gonna show a little bit more on coverage in the next slide. But here, since we are sequencing less genes with a panel, you can have the sequencer and the computers to look at those genes more than what they would do with in 20,000 genes as an exome and genome. So you have higher coverage. And again, we're going to talk about this later. And then cost, of course, it's important. So for panels, usually you pay less than what you pay for sequencing more genes and doing like exome sequencing or genome sequencing. But then to develop a panel, you have to spend a little bit more time because you have to review the literature, understand what genes are important for that particular phenotype, right? So you have more efforts upfront, and then you have to have a specific hypothesis as well, right? Whereas with exome and genome, you can be a little bit more agnostic. Of course, we are going to focus on some genes that are related to kidney disease, but you can be a little bit more loose, right? And then the technical requirements and analytical difficulties and counseling efforts, those increase if you do a broader test as exome sequencing and genome sequencing. Does it make sense, Mira? Okay.
Absolutely, absolutely.
Awesome.
It's a very nice visual.
And please stop me anytime if you have any questions or if someone from the audience has any questions. Happy to stop here. And since I talked about coverage, I think that's very important to understand why we're talking about saying that panels have higher coverage than an exome or a genome, right? So when we talk about coverage, it means that the percentage of the gene that has these black bars here, these black bars are reads that come out of the sequencer, okay? So when I say that a gene is 90% covered, it means that 90% of the gene length has at least one of these black bars here, one of these reads. But 10% of this gene, for example, here in this example, it's not covered at all. So why this is important? If you see a negative result, you can go back to your methods and check if the gene that you're interested in has enough or 100% coverage, right? If you don't have 100% coverage, maybe the variant that's causative for patient's phenotype is in that coverage, in that region that you don't have any coverage. And the same for read depth. So this is important here. What this means is read depth means that, for example, in this orange bar here, this region of the gene, so this variant here has 1, 2, 3, 7 black bars, meaning that at that position, the sequencer read that variant 7 times. And if you go higher, you are more confident, right? Because if you have out of 100 reads, 50 of those reads have that variant, you're very confident that this is a heterozygous variant. But out of 100, if you have only one read that has that variant, could be an artifact, and it happens, right, with sequencers. So for example, in this region here, this variant here has only 2 reads, right? So it has lower coverage or lower read depth than this region here. So if you're gonna compare panels and exomes, usually what you have is panels with these amounts, and of course it's way higher than 7, it's just an example here, but you have these amount of reads in each position, so you are more confident in those variant calls than you are usually when you use an exome because you're looking at 20,000 genes at the same time. Okay, so this is coverage. And you asked me about the tests that are available, right? I think that's one of the most important parts here of this webinar. So we have multiple partners, multiple good labs that offer genetic testing for nephrologists, okay? Those are the partners that we usually use here at Mayo, but there are, and I have to say that there are multiple other labs and other academic centers as well. There are many universities that they put like very good gene panels, and they do exome sequencing and genome sequencing for nephrology as well. And what type of tests these labs they offer? First, we are talking about genomic testing, like panels and so on, but still there is a place for single gene analysis. And I'm going to give you a single example. For example, I've talked about Fabry disease, right? If you have a patient with a suspicion of Fabry disease, you have biochemical evidence, kidney biopsy evidence, and other things, you don't need to do exome sequencing. You don't need to do genome sequencing at first. You can go and do a single gene sequencing. And this single gene analysis can be done with Sanger sequencing. That's a little bit more older type of sequencing a gene. But many times the labs now, they are using what we call next generation sequencing, NGS, and they do a panel for a single gene, because it's more cost effective. So you have more reads, you have like a higher coverage for that gene, because you're doing a NGS. And at the same test, you can actually call deletions and duplications as well. So deletions and duplications are types of variants that are very important in nephrology. They are important in many different phenotypes, but in nephrology, they are very important. There are some genes that the most common variant or pathogenic variant is a deletion. So we have to be aware when we do exome sequencing, that's because of the way that the exome is done, we can miss some types of deletions and duplications as well. So this is important, okay, when you're talking about limitations of the genetic testing. And what actually is the cost of these tests? The cost ranges depending on the lab and depending on the type of panel or exome. It ranges from $250 up to $2,500. And this is depending on insurance coverage, this is depending on patient pay price, out of pocket, and there are many like things that we have to consider here. But there are out there gene panels costing $250, which is very similar to different or other tests that we do in nephrology, right? So in the past, we had like this thing that genetic testing is super expensive and nobody's gonna pay for it. And based on our experience now, we know that the insurance company, they are covering more than 90% of the cases. And usually the patients, they pay from $0 to a couple of $100 for genetic testing. So I think that's another thing that's important here for today.
And I think our genetic counselors also play a big role in helping gauge the cost coverage and the implications financially, as well as ethically,
for sure,
for the patient. Sure. So,
and I'm sure that Brittany Thomas is going to talk about this because that's a big part of her work. So, and to give you an example, and I think this is important as well. So, when you say that you did the genetic testing for your patient, you have to understand what, even though you say that you're doing like a multi-gene panel, you have to understand what this means. And this means different things depending on the labs that we are using, okay? And I'm gonna give you like a real example here. I went through the labs websites just to take some snapshots and show you here. So for example, there is one lab that if you wanna test a patient with nephrotic syndrome, you have to order this progressive renal disease panel. And this panel includes 18 genes. A second lab, if you see like nephrotic syndrome or FSGS, it includes 55 genes. Another one, again, nephrotic syndrome and FSGS, 72 genes. And this next one here, Again, a comprehensive glomerular proteinuria NGS panel includes 76 genes. So again, if you did the genetic testing, your genetic test is negative for your patient, you have to check what type of genes were included in that genetic testing. Maybe the variant is in a gene that's not covered. Okay. And my next slide is about the genomic testing report. And this is a mock one. It's very similar depending with different labs, but there are some parts that are important that I'm gonna highlight here, okay? So the first one is, as we said, the test requested. And in this lab, the test requested, it's called nephrotic syndrome panel. But to me, it doesn't mean anything. I just show you that it could be like from 18 genes to 76 genes, right? So we have to understand what's included in this test here. Then you have the clinical indication. Then you're gonna have the results part. We're gonna spend a little bit more time on the results part in the next slide. But here, you usually will have the gene name. You usually will have the mode of inheritance, and we didn't have the time to talk about dominant and recessive, and if we have the time, we can discuss this a little bit later. And then the variant, they are gonna show you a variant in a C dot and a number here, and C dot means that this comes from the cDNA, and it's the same variant in a different nomenclature here with a P dot, meaning that this change in the DNA means this change in the protein. Okay, and then the lab is going to give you the zygosity. So that's why it's important if we have parental samples. It's hard when we are dealing with adult patients, but if you're dealing with children, it's good to have parental samples because you can see or you can check if the variant has been inherited from one or another parent, or if it's de novo. And this is very important. If it's de novo, we usually are interested in de novo variants. Okay, and then you have the classification here, and this I'm going to spend a little bit time in the next slide because this is a big issue, right? And then you can see this lab here, they offer deletion duplication analysis based on the data, and then they provide some sort of interpretation. Okay, and in this interpretation, usually they are going to give you some more information on the gene, what type of diseases this gene could cause. They usually use some sort of computer programs to call a variant if it's deleterious or if it's neutral. And this changes depending on the lab as well, so be aware of that. They usually give you information if that variant has been seen in larger data sets, and we do have available hundreds of thousands of exomes and genomes of what we call the control population. Sometimes we call them the healthy population. It's not true. They are not completely healthy. But when we are dealing with rare diseases, they are a good database where you can filter variants based on the frequency of the variants in that database. Okay, and then the lab will give you some more information if this variant has been seen in other affected individuals in the literature and many times in the lab database. So this is another point. Choose a lab that is very well known for doing like genomic testing, because the internal database is very helpful to interpreted variants as well. Okay, so and I'm speaking for myself. Usually you stop in this region here, right? But there are some important regions of the genetic testing report that you have to take close attention. And one is, as I said, the genes that are included in the tests. And usually it's in the second or third page of the clinical report. And the other one is the method that the lab used. Okay, so here you're gonna see if the panel, it was a targeted panel, if the panel was a panel based on exome or a genome, maybe in the future, and we are still start doing something like this. And in the methods, they are gonna say how they call the deletions and duplications. Okay, if they did another orthogonal test, or if they only use the NGS data to call that. Okay, Mira, do you want me to stop here before talking about the variant interpretation?
Yeah, if it's okay, I'll just interject with maybe a couple of questions.
Sure.
So I'm putting my hat on as a practicing nephrologist, perhaps outside of Mayo, without the luxury of having the level of support that that guides what to do with the results and how to interpret them. How would you advise a general nephrologist to evaluate different panels available to pick the one that is most likely to provide the best outcome, or be the most inclusive? What things should we look at as we compare the different panels that are currently available from different industries out there?
That's a very, very good question. And we have the same discussions over and over here at Mayo as well. So first, and there are two ways of doing that. If you're completely clinically focused and you have a very specific phenotype, pick the panel, a target panel that has good coverage, who can provide you deletion and duplication analysis, and if possible, that covers the genes that you know are important, right? So for example, if you're dealing with what we call the Alport syndrome, right? We are trying to not use the Alport syndrome name anymore. It's more on the collagen 4A related diseases, right? But if you're suspecting of this disease, you have at least in your panel, you have to have the 3 collagen 4A3, the 4A3, 4A4, and 4A5. And we know out there, based on literature, there are many other genes that are associated with Alport or the collagen or the FSGS, right? I would say that 18 genes is not enough, because if you review those 18 genes, there are some important genes now that are not included there. So try to be try to review those genes, at least to know that you don't have so many genes that are not related to the phenotype at all, but you have enough genes that cover for the phenotype that you're interested in. Okay, and this is clinically focused, and a targeted panel always going to be cost effective on the clinical side. So if you're interested in doing more on the research side, then you can order a customized panel based on exome sequencing, because then you can ask, for example, if the first analysis of those genes that you are interested in is negative, you can call the lab, or you can actually get this data back and then review manually for variants in other genes as well. But again, it depends on where you are and what type of resources you have.
So I'll follow with another question. So most of us, I'm going to include myself, I don't have all the gene names memorized, especially if we're going down to nephrotic syndrome, or the list can be quite much longer than when we're thinking of collagen-related mutations, for example. Is there an available resource, a publicly available resource for nephrologists to figure out, okay, these are the genes that have been described or discovered that fall under the different panels, so we have a perspective of which panel is most inclusive?
So there are some softwares out there that based on the phenotype, you can create gene panels, okay? But I don't think they are very user-friendly for everyone here, okay? So I would say that go with a lab that you know based on reputation, that you know that they have good clinical geneticists and lab geneticists and genetic counselors. And usually these labs, and those that I showed you, they put a lot of effort in creating and curating gene panels. I would say that you can trust those labs, you know? And then if you have any questions about what type of genes that are not included, you can call the lab or email the lab. They would be very happy to discuss this with you. But I would say that you have to go to PubMed and review some new genes every once in a while, and it's impossible to do this with our busy clinics. I get it. So pick a lab based on that list that I show you. Pick a lab that you know that's good, and go with them.
This is very helpful. Thank you, Filippo. So maybe with that, we'll transition to what do you do with the red report, uncertain significance? What does that mean, and how can the provider consider next steps, or based on what knowledge or data points to help guide further evaluation of that?
Sounds great. So first, variants are classified in different ways, okay? Depending on the lab, depending on the country that you are. So there are many different guidelines. And here in the US, you have what we call the ACMG, so the American College of Medical Genetics and Genomics, and the Association for Molecular Pathology Guidelines. These guidelines were put together in 2015. And just after they published these guidelines, each of those, and I'm going to talk about this criteria in a moment here, but each of those criteria, they start to be reviewed, right? Because knowledge is evolving. Every day we have more knowledge or more literature on some genes and on how we should interpret it. So one thing before we talk about variant classification is to understand that there are some criteria that are subjective. We try to be as more specific possible here, but there are some that, depending on the lab, they are going to call them differently. And variant classification is dynamic. So today, this variant is classified as variant of a certain significance, but tomorrow, because someone published something about that variant, you can reclassify this variant in a day. Okay, so just keep this in mind. So if you did a genetic testing like 3 years ago, just review it again now, because maybe you have enough evidence now to reclassify the variants. Okay, and this is common sense. We know we have been doing this in our practice. So this table here shows the criteria that is used to classify a variant, and you can see that going to the left, you have more on the benign side, and then on the right, you have more on the pathogenic side, right? And in the middle, you're going to have the variants of uncertain significance. So in the past, again, speaking for myself, when I got a report saying that a variant was rare and the computer algorithms called this deleterious, I would say that the variant, it was probably the cause for my patient's phenotype before 2015. We had different guidelines, right? After 2015, now we are more strict how we're classifying variants. So if someone tells me that the variant is rare and the computer programs call this deleterious, for sure you're not gonna call this variant likely pathogenic or pathogenic. You need more evidence to call this variant higher than a variant of a certain significance. Okay, and here is some of the criteria. So one data that the lab uses is the population data, and that's what I told you about this population database with hundreds of thousands of genomes and exomes in healthy, and I'm air quoting here, healthy individuals, okay? And so based on the prevalence of the variant, so if the variant that you're seeing in that patient with that phenotype, if the variant is very frequent in the general population, probably it's not causative for patient's phenotype, right? Because you have a lot of other individuals without the phenotype. And then you see the second one is the use of some softwares. In these softwares, they work in different ways. Usually they analyze how the variant impacts the protein based on conservation, based on type of change. So there are many ways to call a variant deleterious. And the labs, they use different softwares. And you can see that one of the word that they use here, one of the words is multiple lines. So multiple lines, what does this mean, right? 2, 3, 15, 50, I don't know. So that's the subjective part that I was telling you, depending on the type of software that they use or the number of softwares that they use. So this could change from lab to lab. And then of course, if you have functional data for that specific variant, probably if the functional evidence it's enough, probably you're going to push a little bit this variant on the pathogenic side than only variant of uncertain significance. But we know that's very difficult in the clinical practice to come up with functional evidence if you don't have like researchers focus on the genes, right? So that's why it's good, and we are going to talk about this, having like a multidisciplinary team. Again, it's not feasible for everybody, but if you have the expertise in house, it's good to put researchers and clinicians together to discuss these cases. But one thing that we can help the lab to reclassify a variant on the clinical side is this criteria here, this segregation data. So if you're testing only one person in that family, the variant is classified as VUS. if you have more affected individuals in that family and you can test those affected individuals and those affected individuals have the same variant, maybe the lab could push this to a likely pathogenic variant based only on testing more individuals. So this is something that we can do on the clinical side. Try to figure out if there is a positive family history and if you can get a hold of those individuals. And having unaffected individuals, there are some labs that use this as evidence. So if they can test multiple unaffected individuals and those individuals, they don't have the variant, this is another piece of evidence that could tell that the variant is actually causative for patients' phenotype. And then, as I said, if you have a trio, it's important to know if it's de novo, because de novo gives you at least a moderate criteria to classify, to put the variant on the pathogenic side. And then there are other criteria. So just keep in mind that variant interpretation is a science per se, because you have so many criteria. The GCs and the people in the lab, they spend a lot of time trying to figure out how to classify a variant. So anytime that you have any questions about the classification, just call the lab to discuss the variant interpretation.
Filippo, could you share with us perhaps a clinical example where it came through as a variant of unknown significance and what helped guide
Sure.
further steps to say take it from that to something that really impacted patient care?
Yeah, I have two quick examples, okay? So one that we did everything on the clinical side, a patient with FSGS, they tested mom, or it was a female patient. They found a variant in collagen 4A5, which is an X-linked disease, an X-linked gene, right? The variant was classified as VUS because they have information only in that individual. Then, with the help of our genetic counselors, they checked the whole family, and actually they found cousins and aunts with some with hematuria only, some with more chronic kidney disease, and they could test those, and these two individuals, they were affected, like Mayo, they're affected, but still affected, and they carry the same variant. And the lab, based on these three affected individuals, now the variant reclassified the variant, the VUS, to a likely pathogenic variant. And this happens commonly. If you can get a hold of other affected individuals, this happens. It's a way to reclassify variant. And another quick example that I have, and probably Dr. Zand is going to talk about this case, but just a preview here. There was one patient with FSGS again that had a variant that was what we call synonymous. So it is a variant that in theory doesn't change the protein. Okay, so you have a genetic variant, you change, like, let's say an A to a G, but then in the DNA there is this change, but in the protein the amino acid is the same. Okay, and usually we filter out these variants. Usually it's synonymous variant, meaning that you change something in the DNA, but in the protein level you don't change anything. Usually they are not causative. But again, this is not true for every case. And for this specific one, this variant was right in the region, in the boundary of the nexon and intron region. And anytime that you mess up with this region, you can impact splicing. Okay, so what we did with help from our researchers, we went to the lab, did a specific analysis of that region, and we proved actually that synonymous variant that we thought wasn't changing the protein, in fact was impacting splicing, and it was a deleterious variant. And then with this information, the lab used this lab information to reclassify a variant to likely pathogenic.
Wow, that is really powerful. And I think it definitely emphasizes how important it is to engage a team, right? With the expertise to be able to think outside the box and figure out how we can turn a VUCG to a true variant or a true negative. So we learned about clinical genetic report, how do we interpret it, what things to take into account. Can you talk to us a little bit about, as a nephrologist, what critical data points are important to gather and have available before pursuing the next step for a genetic referral?
Awesome. Yeah, that's a great question. First, of course, the clinical history. This is important. We need to understand if the phenotype, how specific the phenotype is, right? And then if there are extra-renal manifestations. I know that sometimes we overlook this because we're focused on the kidney only, but there are some like very easy questions that during your interview you can ask about, like hearing problems or eye problems, or if someone in the family had any type of problem. So getting a family history is very important as well. Of course, with the help of genetic counselors, they do like a very, like they analyze the whole family history, but during your consultation, you can do like a basic thing, just asking if the same phenotype or even, and for example, for the Alport and collagen for diseases, even hematuria. So hematuria could be a sign of the disease, right? So, and sometimes these patients, they think that they are completely asymptomatic because hematuria is not that problematic. So family history, at least the basic family history, imaging. So it's very important, imaging, and whenever possible, kidney biopsy, right? Kidney biopsy with electron microscopy. This is very helpful when we are dealing with genetic testing results as well. I would say that this would be the information that we have to capture.
Thank you, Filippo. I'm gonna break and introduce Dr. Hatem Amir's question before I ask you more questions. So his has to do with the VUS, and the question has to do with VUS designation in a kidney recipient. And it's a concern if there is a related living donor that comes forward. And so his comment is being specific in what that VUS is important to avoid mislabeling, but it does affect the sensitivity of the test. So the question is, how do you deal with a recipient donor pair that has a VUS?
That's a great question. Thank you. And I know why he's asking that, because we always have these discussions. It's very important, very important. And I'm sure that Dr. Otiers is going to talk more about this. And it's not an easy answer here, right? So what we decided, so taking a little bit from our colleagues from the oncology, right? So anytime that you do genetic testing for oncology and you find a VUS, they have some guidelines that you don't take any clinical measurement, like you don't change clinical management based on VUS, okay? But to take, you knowing that you have a VUS, you have to remind like the family or even the colleagues that it's important to get more information in some months for sure. So in nephrology, what we did, we follow the same pathway in a way. So if we see a VUS, we bring to a multidisciplinary team. We discuss with our colleagues with different expertise, pathologists, researchers, genetic experts. And if there is not enough, or there is no other information that could help us reclassify the variant, we would stay with a VUS, and we wouldn't change the clinical management, or we wouldn't defer anyone from being a kidney donor based on a VUS. But there are some cases that sometimes the lab cannot report the variant as a likely pathogenic because they have some cutoffs for that criteria that I just showed. But in this multidisciplinary team, we come up with, okay, there are some publications out there that are saying that this variant could be related to the phenotype. So in this patient, for example, probably the discussion is a little bit different. If there are other available donors, probably we would go with the other one. But it's a very good question. It's hard when we have VUS. It's hard to make any assumptions.
So you really have to get as up-to-date data as possible to call it one way or the other, and then gather more information.
And always be clear with the family as well, right? Because what's a VUS? It's something that nobody knows now, right? And this could change, as I said, in a day. So the family should understand what this classification means as well. And the discussion about donor should be donor and recipient should be with the family for sure.
So as you made the comment that things can change every day, how do you see genetic testing or testing outcome influencing kidney disease in general now or maybe in the next 5 years?
Well, it's changing now. That's a very good question again. So first, I would say prognosis, right? So we know that depending on the type of variant that we are seeing, we can provide some more information to the patient. We know that there are some variants that causes more severe phenotypes that these patients would evolve a little bit faster than others. So this is something that we can use now. Second, to different management. So for example, if you know that a patient has a genetic form of FSGS, you're not gonna prescribe immunosuppressants, right? And this is very common. So if you can not use immunosuppressant will be the best for this patient, right? Or maybe the need for extra-renal manifestation screening, right? So if you have a genetic diagnosis for an FSGS, you have to test for hearing loss or eye problems as well. And I would say that third, and we talked a little bit about this with the transplant, would be the family cascade testing. So as soon as you detect one person with a genetic variant that is like pathogenic or pathogenic, you can test other family members and you can change management for other family members, right? So you can detect asymptomatic individuals, you can change their management even before the symptoms start. And as you are going to see with Dr. Altiers, we actually change management for some families based on genetic testing as well.
I think it's important to emphasize that there is the impact of genetic testing. It's not just knowledge. It really does have a clinical implication. It may not always be change in treatment, but it could be change in prognosis. It could be avoiding a treatment, as you mentioned. So there is an important impact that has to be put in the context of everything else that we do for this patient and the relative cost, right? And the perspective of everything else that we do to evaluate their disease. Where do you see maybe current or future barriers to making really genetic evaluation for kidney disease more commonly used and more available to the practicing nephrologist?
Yeah, at the beginning when we started this program, we thought that cost would be like a big barrier. And actually, after some years, we now know that this is not the biggest because, as I said, like 90% of the cases, insurance companies are covering the tests, right? So one thing that I feel that's a barrier is paperwork. So it's burdensome. We have busy clinical practice. All this genetic testing, you need to fill a lot of forms and then consents. So this takes a lot of time. And there are many colleagues that I know that it could be important, but I don't have the time, right? And this is true for any practice. So we, with SIM support, we created something to help with the ordering process, what's called GTEC, that's Genetic Testing and Counseling Unit. And that's what Brittany Thomas is going to talk about. So at least knowing these barriers or these problems that the nephrologists had, we try to accommodate or to organize the process. And then another problem is the interpretation of the results, right? Interpretation and return of results. So I would say that anytime whenever possible, you can do it, put together a multidisciplinary team, put together geneticists, genetic counselors, nephrologists, pathologists, fellows, because we have to train people to, because that's not the future anymore, right? We are doing this every day now in the practice. So we have to train people because, to be honest, during med school, I spent, I would say, like a couple of hours understanding genetic testing only. And now it's common sense. We have to understand genetic results. Right, and having this multidisciplinary team helps to determine the best next steps for the patient as well. So, but again, we have to start from somewhere, right? Our patients need this integrated type of care. So,
thank you, Filippo. I think that says it so nicely and kind of along the lines of the med school. I thought the same thing. You learn a couple of nuggets here and there. Even in fellowship training, I think. being a fellow at Mayo Rochester is a huge blessing and probably gives you a different perspective on training. But in general, we don't have a structured genomics of kidney disease curriculum, which we kind of hope to repurpose this webinar series to help serve that.
Sure.
Do you have any other thoughts or questions before I open it to everybody else for Q&A?
No, I'm happy to take any questions.
Okay, we've got 10 minutes if anyone has any questions. Maybe while we're waiting, I'll ask one. How often does ACMG update their guidelines?
So since 2015, they don't have a new one, but they have been publishing for each criteria. They have papers on each criteria now. And so like every year we have updated criteria. Actually, Mira, I have one thing to say. I think that's helpful for patients, for you that have been seeing patients with tubular interstitial disease. I think we didn't talk about this limitation. I think that's a big limitation. And for sure, Dr. Hogan is going to talk more about this, but I just want to, again, give like a preview. So there is one gene that it's very important for tubular interstitial disease that's called MUC1, okay? And anytime that you have a patient with this phenotype, you cannot rely only on the NGS panels or exome sequencing or even genome sequencing, because the variant that causes the disease, it's in a region of the gene that's not well covered by these technologies. So there is another type of testing that's done only on the research side to analyze this specific type of insertion that happens in MUC1. So just keep this in mind. If you have a patient with this phenotype, negative genetic testing, remember that you don't have enough coverage for MUC1 in these tests.
Thank you, Filippo. I think, I hope that at the end of this, everyone is empowered to think of genetics as part of your diagnostic toolkit as you evaluate patients in the nephrology clinic. Oftentimes, genetics is either an afterthought or no thought at all. And so putting it up front and center and realizing that it can truly impact patient care is the first step. And then the next step is creating the team, like you said, because it's great to know, but the feasibility is going to be a big issue, especially as as we think about our colleagues not affiliated with a large academic institution and trying to develop that support on their own, right? Identifying genetic counselors, geneticists, and work with a team to help make this process easier. And it'd be interesting to see in the future if there is some interest among the different industries that are coming up with these new panels to make the process easier for the provider to kind of incentivize referral.
For sure, completely agree.
Okay. It looks like we may be ending about 10 minutes earlier. Just to give you a preview of what is to come, Dr. Hogan will be discussing with us implementing genetic testing in the nephrology clinic. So a little bit of a different perspective that we learned today, and that will be coming up in just a couple of weeks. Dr. Elters will be teaching us how to incorporate genetic considerations and genetic testings for the transplant nephrologist. And then Dr. Liskey will be teaching us about kidney stones and the role of genetic testing in both the evaluation and guiding management, and that will be in July. And then we'll talk about the genetic counselor role, which is really powerful, and we'll have a panel to discuss that in August. And at least for this year, we'll end it with Dr. Zan's talk on glomerular disease. And hopefully we'll continue the series depending on interest and how things evolve. So thank you everyone for taking time to participate with us. Thank you so much, Filippo, for taking the time and educating us today. And we look forward to learning more from you in the future. Hope everyone has a wonderful afternoon or morning, depending on your time zone. Take care.
Thank you. Thank
Bye-bye.
you very much. Have a good one. Bye-bye.
Bye-bye.